Hello there, and welcome to the Surgical ICU Rotation at LBJ Hospital. My name is Dr. George Williams. I'm the Medical Co-Director of the Intensive Care Unit, and we're thrilled to have you coming and joining us on our service. This video is intended to provide you with an overview of the various points of information that you'll need to be able to function effectively as a resident on our service. So come on, let's go in. Code 2, 4, and 3 is used to open all of the doors in the ICU. Remember, to avoid a catastrophic embarrassment, please lock the door when you use the bathroom. The break room can be accessed using code 2, 4, and 3 as well. The break room has a refrigerator that is available for residents as well as a freezer, and 2 microwaves that can be used. In the event of an airway emergency, calmly walk to the medication room, which is badge access only per CMS guidelines. Here you will find an airway tower which includes a drawer that has MAC 3 and MAC 4 blades and their corresponding handles, masks and face shields for your protection, and a drawer with oral airways, McGill forceps, as well as end-tidal CO2 detectors and syringes. Endotracheal tubes and LMAs can be found in the exact same drawer, along with bougies, which allow for convenient placement of the difficult airway. Finally, the last drawer includes cricothyrotomy and thoracostomy kits. There is a station for blood gases as well as iStats, so that we can promptly process labs in the ICU. In the likely event that you require nourishment during your rotation, you can use the 243 code to open the nourishment station, which includes a water and ice dispenser, as well as cups and cutlery, which are readily available for use at any time. Each computer has an emoji display to indicate the charging status of the station. Simply remove the battery from the back if your station requires more battery power. Go to the UV light sterilizing / battery charging station. Remove your battery and replace with the depleted battery, and take the fully charged battery, put it right back on the back of the computer station so that you're able to continue utilizing your workstation without interruption. Being available constantly for telecommunication is important and critical during your rotation. Simply swap the SpectraLink batteries at the beginning of each shift, either nighttime or daytime, by taking the battery out of the telephone and replacing with the telephone on a port that is lit green, indicating that it is ready for usage. Once the battery is placed on the back of the phone, make sure to press the on button for 3 seconds to reactivate the phone. The phone is now ready for use. There is a team room available for SICU residents to be able to work efficiently. You will find that there is a large screen which is ideal for academic presentations, as well as 4 individual workstations which allow each member of the team to have their own workspace. In addition to a laser printer and coat hangers, you will find that there is ample space for your bags and other equipment. In order to use the large display that is mounted on the wall for educational purposes, take the keyboard out of the cabinet and simply click the mouse, which will activate the screen, and log in using your regular Harris Health login information. In order to facilitate an environment of inquiry, 2 of the computers in the workroom are fully functional University of Texas computers. Simply switch from the Harris Health computer to the UT computer by clicking the select button. Once you do this, it is easy to log in using your UT account. The clean supply room requires badge access, but once inside, you'll easily be able to find sterile gloves of various sizes, as well as other personal protective equipment such as sterile gowns and surgical hats. In the alcove across from bed 4, you'll see the adult code blue box, which among other things includes central line kits and arterial line kits readily available for use and always stocked. Additionally, you will find other surgical equipment such as anticoagulation kits, as well as suture kits, arterial line catheters, and arterial line wires. Across from bed number 5, you will find a defibrillator which is always charged and ready for use. The equipment room is badge access only, but it includes important devices such as the bronchoscope tower, which includes a large view screen and multiple drawers full of equipment. In the second drawer from the bottom, you'll find the CMAC 3, 4, and D blade, along with a light wand, which is easily activated by plugging into the receptacle. Performing bronchoscopy is also easy with the bronchoscope kit directly connected and compatible with the CMAC tower. A dedicated ultrasound is available for use in the SICU with a phased array or cardiac probe, linear probe, or abdominal probe. These probes must be cleaned with the provided sanitizer so as not to damage the probe. The call rooms are located on the 3rd floor of the hospital. Following this route, outside the operating room, you can walk to the medical intensive care unit area where you will see the door secured by the key card that you've been provided. This room is available to you whenever you need rest. And most importantly, remember to keep a constant presence on the unit with our nursing partners in order to provide excellent patient care. Now let's go over some facts that you'll need in order to be able to function clinically well on this rotation. Critical care is a key part of anesthesiology. It goes back to the very beginning of the practice of our profession, and so in order to provide care for the ICU level patients that you will regularly see in the operating room, and furthermore, to be able to understand the role that anesthesiology plays in the provision of critical care is very important towards your education. Of course, at the end of this rotation, we want you to be functional in the critical care setting, but also to understand the thought process of the surgical teams that are sending patients to us, as well as perioperative patients in general. But our modus operandi in our unit is to help and be a resource to the hospital and to the surgical services. And in order to do that, we have to communicate well, communicate well, and communicate well. And furthermore, if the surgical service asks for a patient to come to our unit, the goal is to provide that care and to be a facilitator, never a brick wall. And of course, the number one goal is to have fun and be educated. A progress note must be written for every patient every day. And this is irregardless if there was an H&P written for the patient overnight, because we need to communicate to the other services and the hospital our daytime rounds assessment for the patient. Please use the template provided here as indicated by .sicu and as progress for all progress notes. This ensures that all compliance documentation is completed, and this note may be regularly updated centrally in order to provide the optimal note writing experience. Medical students that are rotating with us should write a progress note for every patient that they see. Please have them send that note to the faculty. However, the resident note must still be written because a student note is not acceptable for billing and documentation purposes at this time. The surgical ICU is a closed unit, which means that our team must write every order or directly electronically approve every order. If a patient is being admitted by the surgical service, they are welcome to write their admission orders, but we have to review every order and make sure that order is understood by the surgical ICU team, and any issues need to be promptly communicated with the surgical team. Besides admission orders, so as to guide therapy, every other order must be written by the surgical ICU team. And it's very, very important that we communicate any issues of a mutually agreed upon order with the surgical team promptly. We always do what the surgical team asks unless there is an issue. And if there is an issue, have your faculty speak to the surgical faculty or make sure there is at least communication between the teams. So being a closed unit comes with responsibility. However, this is much better for patients. All patients that are admitted to the surgical ICU are admitted to the attending SICU physician on Epic. For new admissions, remember that your faculty are on call 24 hours a day, 7 days a week while they're on service. Therefore, every new admission must be staffed with the faculty on call, either in person or via phone. But every new admission must be staffed with the faculty on call. That being said, there is a nighttime pulmonary critical care medicine fellow that is a resource for the entire hospital. They are not a resource only for the medical ICU. So interns that are on call should universally staff each patient with the fellow and the faculty, but the faculty must still be involved in directly deciding what plan of care is executed for the patient. As the faculty is ultimately responsible, the faculty cannot outsource this particular task to the fellow. That being said, for PGY2s and above who are more familiar with different monitoring techniques, clinical scenarios, and acute care management, a PGY2 and above can staff directly with the faculty, but the fellow is available as a resource if needed, not only for the medical ICU, but also for the surgical ICU and for the whole hospital. But the faculty will decide what patients come to the SICU, what patients don't. As a resident, you are not expected to determine who should or should not come to surgical ICU. The faculty are essentially going to say yes to every patient that comes, but knowing whether or not the patient is appropriate for the surgical ICU, whether or not there are certain clinical circumstances or conundrums that need to be considered, should be in the faculty's domain, and they should provide instructions to the resident on call. Any patient admitted to the surgical ICU requires a history and physical that is documented and in the chart. It is important that you do not leave your call shift or daytime shift if there is an H&P pending for a patient that you have already admitted, as it can lead to worse outcomes for patients. Any patient that comes from a surgical service, we automatically admit and we accept them, period. Any patient in the OR that needs a SICU bed should come straight to the SICU unless the attending anesthesiologist has specific concerns necessitating them going to the PACU. Patients can be boarded in the PACU, and the surgical ICU service may follow them there if there are no beds in the surgical ICU. The goal is to rectify this as soon as possible, and of course this requires close communication with the PACU staff and nursing. Medical patients should go to the medical ICU unless it is full, and this must be confirmed by a faculty-to-faculty conversation. If the emergency department calls, be friendly. We're here to help. If they say the MICU is full, no problem. Have your faculty reach out to the MICU while you ask for the ED physician to stand by while you call them back. When admitting a patient, please use the new patient H&P template and start early if possible so that there's less work for you or your colleagues later. If there's a patient being admitted from the operating room, go to the OR and see the patient and speak to the anesthesiology and surgical teams intraoperatively whenever possible. Additionally, every morning, please check the OR board to see if there are any patients that are scheduled to come to the surgical ICU. Communicate your needs directly with the bedside nurse. Don't trust the orders to communicate your concerns. And finally, once again, the surgical team can place or assign and hold orders for admission, but please review them and adjust as needed in consultation, of course, with the surgical team. Daily rounds start at 8 a.m. Monday through Wednesday and Friday universally. However, on Thursdays, it may be pushed back to 9 a.m. or another time as coordinated with your faculty, as anesthesiology and surgical faculty have grand rounds on Thursdays, and so do you. Additionally, on Saturdays and Sundays, rounding time is 8 a.m. However, please confirm the time with your faculty, as because it's a Saturday or Sunday, times may vary based on ambient conditions throughout the city. Multidisciplinary rounds are joint rounds with case management, the charge nurse, the pharmacist if available, physical therapy, occupational therapy, and social work. They occur every Wednesday through Friday at 11:30 a.m. and their purpose is to help get patients out of the hospital more efficiently with lower cost to the health system and to the citizens of Harris County. This is really done by providing a very brief, less than 45-second overview of the patient's needs, and which may be current or anticipated needs, i.e. someone's going to need home health, someone's going to likely go to a long-term care facility, Only one resident is needed for multidisciplinary rounds. The senior resident should get comfortable performing these rounds by the end of the rotation and should do them as regularly as possible. Multimodal pain control is a mainstay of controlling pain in the surgical ICU. We try to avoid opioids as much as possible. Please review this slide to become comfortable with common drugs, and all these drugs should be fully scheduled before adding opioids in most instances. Of course, please adapt your plan based on the patient's medical presentation and needs. With regard to placing orders, it is important not to use common acronyms such as QID or TID. Please use every 6 hours, every 4 hours, every 12 hours, etc. And additionally, we do not use verbal orders unless the patient's coding, please. There's an order set for almost every indication, so feel free to use them as long as you read the content of the orders to understand what you're giving. And please speak to the clinical pharmacist every weekday and also weekends if needed, particularly for drug dosing of antibiotics or other drugs that we do not commonly use. This improves patient safety. As the surgical intensive care unit is the landing/home unit for all subspecialty surgical care, we will commonly see plastic surgery patients. These patients will frequently be admitted to the surgical ICU following extensive and lengthy flap procedures. The flap care and checks that the surgical team requests are very important and must be adhered to very closely because the ramifications for the patient and the hospital are substantial in the event of a fallout. Because of this, there is a bedside handoff that is expected that we consistently participate in and team members are at the bedside for. Furthermore, it is important to remember that these patients are high risk in that very subtle changes in physiology, blood pressure, or coagulation status can cause a loss of a flap. While these cases may seem routine, when something goes bad, it goes badly. So we have to be very vigilant. That being said, there's a protocol for these patients that is posted in the team room, which we have collectively discussed with the plastic surgery team. If there's ever a question about a patient, please contact your faculty and the plastic surgery fellow. They are always more than happy to help, and they definitely want to know about every procedure or event of every patient they take care of. Your education is paramount, and in order to facilitate it, we have scheduled multiple education conferences for your edification. The first of these is Journal Club, which takes place every third Thursday at 6 p.m. in the Anesthesiology Conference Room in the blue section of the medical school, right outside the residency, academic, and education offices on the 5th floor. The call resident that is on call the third Thursday at 6 p.m. should plan to arrive in the ICU by 5 p.m. so that the rest of the team can realistically be expected to arrive at the medical school in time for Journal Club, which begins at 6 p.m. In order to make sure that this call resident isn't essentially penalized for coming in an hour early, we ask that the senior resident on the service somehow facilitates this call resident to get back their hour that they have contributed to the team to ensure comprehensive education for the entire team. The call resident is not left out of the Journal Club educational experience. The UT computer that is in the work office in the ICU has been configured and pre-installed with WebEx. So the resident is expected to click on WebEx at 6 p.m. and attend Journal Club remotely so that they can participate in the discussion and learn as well. This link will be emailed by the office staff and it will be embedded in the calendar invite. The next educational conference is the TRISAT Consortium Lecture. This is a conglomeration of lectures that are given live nationwide by a variety of institutions, which is hosted by the University of Texas San Antonio Health Science Center Department of Anesthesiology. Faculty from our department as well as other departments from around the country also contribute lectures to this consortium. It takes place at noon on Tuesdays, and the email link will be sent by the residency office for residents on their ICU rotation in the SICU. Use of the UT computer is really encouraged in order to facilitate viewing the presentation, not only because of video conference connectivity, but also because of the speakers that are attached to the UT computer, which have more output than the rest of the speakers in the room. Fellows are required to attend this conference, so if you have a fellow on during your rotation, they will be required to actually leave the ICU and be physically present in the medical school for this conference. Additionally, you're encouraged to attend Grand Rounds, which takes place on Thursdays at 7 a.m. Miss Natalie Vu from the chairman's office normally sends out a weekly data or Department of Anesthesiology teaching and assembly email in order to educate everyone on the times and topics of this conference. You can use this link to actually watch Grand Rounds from the workroom or join the rest of the Department of Anesthesiology faculty and residents and nurse anesthetists in the third floor conference room. But if you leave the ICU, just as always, please make sure that you keep the SpectraLink with you or someone is on the unit with the SpectraLink at all times. With regard to overnight call, a MICU fellow is available for any urgent or bedside issues that you have or that you can't handle. If there's a line that you don't know how to place or there's a procedure that's indicated. However, it is important to remember that your faculty are on for 24 hours at a time, so please call them with any admissions. That is their purpose. The bedside fellow is there to help you with routine matters that would not necessarily require the faculty. Airways must always be staffed by the attending physician, either the ICU physician or the anesthesiologist on call. Thank you very much for listening to this presentation. On behalf of Dr. Billy Gill, who's a surgical co-director, and myself, we look forward to working with you during this rotation. Please email any questions or concerns at any point in your rotation to me. It's my job to make sure that you have a successful and outstanding educational experience. Enjoy your time in the surgical ICU.